Hi, I'm Dr. Jack West, and I'm an associate clinical professor in medical oncology at the City of Hope Comprehensive Cancer Center, and I'm also the founder and president of GRACE, Global Resource for Advancing Cancer Education. And I'm very happy to be joined today by two of my colleagues who are also on the board of directors for GRACE and have long been committed to patient education. And so I'd like to introduce and have them give details on their own positions. First, Dr. Jared Weiss, if you can say a bit about yourself.
Sure, I'm Jared Weiss, an associate professor of medicine at University of North Carolina's Lineberger Comprehensive Cancer Center, where it's a privilege to take care of patients and run trials in lung cancer.
And also Dr. Ben Levy.
Yeah, I'm an associate professor at Johns Hopkins School of Medicine and the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. And like Jared, it's a pleasure to take care of lung cancer patients and deliver hopefully great care and great science to these patients.
Excellent. We're here today to give an update on where we are in the battle against coronavirus and also the implications of coronavirus in our own treatment of lung cancer and potentially other cancers. So we had an initial discussion now a couple of months ago as we were in the thick of that first wave, and we were coping with that. We talked a bit about telemedicine and also increasing the intervals between our treatments. And many of the interventions we initiated included kind of kicking the can and holding off on some interventions with the thought that our situation might be fundamentally different in several weeks to months. We are now at that point, and I would say that unfortunately, it's not remarkably different. It's not that we've come out the other side and it's business as usual. In many states, including, I would say, all of the states that we are in, we are seeing some escalation in cases, if not a full-fledged surge, and growing concern and potentially need to clamp down further. Can you give a sense? We're all in different parts of the country, and I'll speak to California, where particularly in Southern California, the number of new cases has been going up quite a bit, and there's, as of the very beginning of July, a sense that we may have a lockdown again, just as we were in March. What about how things are where you are, both in terms of the rules of the game and the general sentiment? Because I'd also say that in California, part of the problem we've had is that there's varying commitment, in a lot of ways, not that much commitment, and especially among younger folks, a great interest in going to the beaches, going to the restaurants, even bars, and this may be fueling the escalation in cases over time. Jared, what are things like where you are?
So we did a pretty decent job of flattening the curve in North Carolina. Of course, flattening the curve doesn't change the area under the curve, or in plainer English, our peak is coming later than most states. We haven't hit it yet. For us, the first wave is not over. We are still in the escalating phase of the first wave. The current projections are for us to continue exponential increase in case numbers until at least late September. The good news here in North Carolina is that until some of the recent openings, every time the models were revised, our peak caseload kept coming down. Now, of course, human behavior has a heavy influence here. This is something that people have a lot of control over. And unfortunately, in North Carolina, and I think the rest of the country, not everyone is doing what we should do both for ourselves, but also our families and the rest of society, which is to say that with reopenings, and gatherings that shouldn't be happening, and failures of mask wearing, for the first time that I'm aware of, our projections actually started bumping upwards.
And Ben, how are things in the DC, Baltimore area?
Yeah, it's a little different. DC currently is in phase 2 of reopening things, and it's been a cautionary tale, similar to what Jared was saying. I think we have to be careful as we begin to open slowly. Our numbers continue to track down. DC is at its lowest numbers since the surge happened, and almost back to where we were at the beginning of this. However, if we look at the modeling from Hopkins, my own institution, it looks like we are heading for another surge come September or October, and we're preparing for that. In terms of are people behaving or not, I will tell you, at least in the DC Baltimore area, you know, a lot of the majority of the public is behaving. I think where the challenges come in is in the younger audience, that we're still having challenges with mask wearing in the 20s and 30s, young 30s, getting these people to consistently wear masks. So, and there's been a lot of push, a lot of public awareness through emails and through signs at local restaurants and public places as a reminder to wear masks. But currently, as it stands now in July 2020, this area is at its lowest point in a long time. And that's not to say that things may not change dramatically. I think what we've learned is that as much as we know about this virus, oftentimes the virus determines its own timeline, irrespective of what the modeling is showing. So we're preparing and trying to make every preparation possible for the second potential uptick in cases.
Now, when we first connected to talk about COVID and coronavirus, COVID being the name for the full-blown syndrome, and coronavirus, the virus itself, it was still relatively early days, and maybe this will be something we're dealing with for long enough that we still look back at this as early days, but we have been learning some over time, including getting some data that the people with lung cancer who develop coronavirus have a disturbingly high risk of complications and in some series of deaths as well. How is this changing management in any practical ways at your institution, and I would say both for lung cancer and more broadly for cancer in general, kind of now and potentially in place for the coming weeks and months? And Ben, maybe I could start with you.
Yeah, I think we talked a lot about this the last go around, and clearly we were trying to come up with policies and procedures that made sense, not necessarily rooted in the data, because we didn't have a lot of data at that time, but what made intuitive sense and scientific sense to do. And clearly a couple of things we did. One was, for better or for worse, surgeries were delayed for curative intent patients. And we moved, as much as we are of a neoadjuvant institution, a large percentage of our patients that were lung cancer early stage back in April and May who would have gotten surgery, many of these patients were unfortunately delayed, and this did give us an opportunity to deliver chemotherapy. Now, you can make
just
the argument.
Just to clarify, neoadjuvant being
prior to
treatment, some systemic body therapy before pursuing the curative intent surgery or potential other treatments. You were saying.
Sorry for that.
No, it's all good.
Yeah, and so this did give us an opportunity to give chemotherapy first, where we usually give it after surgery. But at the same time, that in itself may pose challenges by further immunosuppressing patients and maybe theoretically increasing their risk of complications from the virus. So that's one thing that we're changing now, and we're starting to get back to some of these elective surgeries. I think the other thing that we were doing, in addition to all the social distancing measures that we were taking for patients to come in, but in general cancer management, we were moving out the interval of treatment. So where their treatment may have been every 3 weeks, we moved it to every 4 weeks, or even every 6 weeks based on some new approvals.
Right.
And that was, again, to limit the amount of patient flow into the hospital. Those were the two big things that we were doing in terms of treatment. I would say that surgeries were delayed, unfortunately, and we often gave treatment beforehand. And in those patients that were on treatment, existing treatment, we were increasing the interval. And things have changed. We can certainly talk about how that's changed in a bit, but we're still doing some of that and trying to do any sort of change in an iterative way that's a little bit longer acting than just doing, cutting it off, saying, okay, it's time to move back to everyone moving back to the same schedule they were before?
Well, one of the other things, my sense was that a good amount of our, let's just give 6 weeks or 2 months of chemo or some other systemic therapy, and then we'll do surgery at that point, was based on a premise that we just have to get through this initial surge of activity, and hopefully in 2 or 3 months, it'll all be behind us. And that's not happening in my senses. Yeah. So you move ahead 2-3 months and you still have the same challenges that you did when you started, that there may not be some point in the immediate future when surgery is a much less concerning enterprise. So Jared, what are things like at UNC, particularly maybe in lung cancer, but maybe more broadly? I know you treat other tumor types, especially head and neck, where interestingly, I mean, a lot of those patients are treated quite aggressively, and they're kind of getting beaten with the treatments themselves to the point that it's pretty challenging. And that was before coronavirus.
Right. So I think, when last we spoke, there was a lot that we did not know. There's still a lot we don't know, but there are some things that we know much better than that. More specifically, when we first spoke, we really didn't know what the risk was for a patient coming into one of our facilities. And I think all three of us were deathly afraid of people coming into our facilities. We're doing everything in our power to keep patients out. And I'll stand by that based on what we knew at the time, that was the right thing to do. My facility, and I suspect yours have done something rather similar, has very strict policies before you can walk in the door. You're asked a series of questions to screen you about how you're feeling, about your contacts, your temperature is checked. It is mandatory that your hands are sterilized in front of a healthcare worker, and that if you're not already wearing a mask, you put one on before you walk through the doors. It's made clear to you, you are obliged to wear that mask in the entirety of your time in the facility. If you are not, you will be escorted out by security. There are other precautions as well, but the gist is very strict precautions. And what I know now that I didn't know when we first spoke is that these sorts of precautions actually work. We've had a fair number of cases, so we have a denominator, and our in-hospital transmission rate remains 0. And I'm aware of many other hospitals that have rigorously looked and also have rates of 0. And that influences my thinking a lot. I'm a lot less scared about my patients coming in than I was when we first spoke. And so that has influenced me heavily. As well, when we first spoke, I would say I was in my honeymoon period with virtual care. And I would say I now have some concerns about my marriage.
You're just talking telemedicine.
Oh yeah, my actual marriage is rather happy. But for telemedicine, I still stand by what I said when we first spoke, that for some patients it can be better care. If you have an EGFR mutated patient on osimertinib who's been doing well 6 months, feels great, there's no reason you can't get local labs and scans, do a quick video appointment, and that's probably better care for that patient even outside of COVID-19 because you're demedicalizing their life. And I still stand by the idea that remote care will forever be a greater part of my practice than it was pre-COVID-19. However, and this may be in some ways unique, particular to the environment I'm in, for some patients I have come to a very harsh feeling that it is dramatically inferior care. The face-to-face connection is not the same. The ability to judge sick versus not sick is the same. Physical exam, now that I don't have it, I realize that it was more useful perhaps than I might have joked the first time we spoke. And then the final point is that many of our patients don't have the resources to do an appropriate telemedicine or video visit. So, when we spoke last time, we spoke a little bit about internet bandwidth, but I'm noting on my video visits that I'm having a lot of visits where I'm struggling to hear every other word. And then to take that a step further, I'm in an environment where some of my patients come from very rural environments. There are even people who have landlines that I can't understand them on a landline telephone. And so I'm seeing some heterogeneity for which situations and which patients virtual care is appropriate for. And I've shifted back to doing more of my care in person.